So what if I kick it off? Patty's just finishing something up, and we'll start it. Happy to open it. Yeah. So we'll just start at our agenda. So just to start with, I'd like to acknowledge country. I acknowledge and pay my respects to the people of the Kulin Nations, the traditional owners of the country on which I am meeting from today. I pay my respects to elders past, present and future, and recognise their continuing connection and contribution to this land and these waters. And I extend this respect to any Aboriginal people who are here with us today. So welcome one and all to our first clinical network meeting for 2025. So the agenda tonight.
We'll have to go now. Yeah, I've just logged in. My camera's not on and I'm on mute, so that.
Kick it off with Carolyn, and then I'll hand over to Shelley, who's going to be talking about her research, and Ellie. Then Ellie's going to speak to some research that she has been involved in that we saw last week at the PD day at the Northern, which was really great presentation. So we thought it would be useful here. So actually, I might go to Shelley first, if that's okay with you, Carolyn, because she's just got two minutes. I mean, you're welcome.
I actually have more time, so go ahead.
Oh yeah, okay, great. All right. So sorry, back to you, Carolyn.
No worries. Thanks, Kath. Hi, folks. Nice to see you. First meeting of the year. I've not really, I'm going to be honest, I didn't do a lot of prep because we've been a little bit busy, and I feel like it's a bit weird because I keep on saying that every time that we meet in these quarterly meetings, but we're again getting a lot of calls. So we had the biggest number of calls ever to 1-800 My Options in January 2025. So it was about 829. We were averaging something like 38 calls a day. Still 98% of people looking for abortions, and still a lot of people really struggling to be able to afford services. So Marianne, when you were talking about a lot of people looking for IUD services that are affordable, that's again something we're seeing when people are looking for IUDs, but people are just not able to afford these services in a lot of primary care settings or in private clinics, certainly. February was busy as well, with about an average of 33 calls a day. So we're still seeing the same barriers in terms of that financial insecurity being a really big one. We are again seeing high numbers of people who are ineligible for Medicare, looking for services, and again, a number of barriers that they're experiencing with access, whether that's again the financial insecurity or distance to travel, or issues around health literacy and seeking care later than we would prefer. Most of the time we're able to support people to navigate across the system, but it can be really complicated, particularly for people who are rural. We're doing a little bit of work at the moment, looking at a lot of medical abortion providers in the primary care system, because there are some that are able to directly bill to some international student insurance companies. I'm sure you will know that international students are required to have overseas health cover to be able to study in Australia, and there are a very few number of providers that will direct bill either the full cost of a GP appointment or a partial cost. So there might be a bit of a gap there, and that can sometimes just make that access point a little bit easier for people who can't front up the upfront fee, especially considering that for someone who's ineligible for Medicare, they're probably not going to get any kind of rebate for an ultrasound, and the cost of the medication is really significant. So around about $350 or a bit less, because they only get about $50 back from their insurance provider. So we're trying to work with the services that we know that do direct bills so that we can get a better picture of that across the system, so that we can help that international students navigate that where appropriate. But it's still a significant gap in the system, and a gap in terms of accessible services in the system. Aside from that, we are doing a little bit of work at WHV. We should have 2023 medical abortion data up on the Women's Health Atlas, hopefully later this month or early to mid-April at the latest, which is useful. And I've also tried to get the 2024 medical abortion data prioritized so that we can get that this year as well, because we want to really be able to see whether the service gaps that we know exist in the system, particularly in a lot of rural areas or areas that have low socioeconomic advantage or high disadvantage, are seeing any change in provision, particularly since the de-restriction and the capacity for nurse practitioners and endorsed midwives to prescribe. So hopefully we'll be able to get that data and have a look to see whether there are any real life changes in service provision across some of those particularly persistent deserts.
Thanks, Caroline. It'll be interesting to see how that data is progressing.
Mm.
Whether those gaps are being filled slowly but surely. Anyone got any questions for Caroline? Thanks a lot, Caroline. And I think we'll forever be calling you 1-800 My Options busy. It's a common theme, isn't it? So thanks for that. Shelley, I'll hand over to you.
Right. So hi, everyone. For those that don't know me, I'm a researcher at the University of Melbourne, and I won't talk for very long, but I would love to tell you about a study I'm doing right now. The QR code to participate should be on the agenda as well as a link. And what I'd love to have you do is not only see if you might be willing to fill it out, but also share it with someone from another state and territory. So essentially what I am doing is building on research I did over the last few years, speaking with abortion seekers who told me about all of the ways they were treated well, but also mistreated on their pathways to care. So I took all of those behaviors they talked about, and now I'm presenting it to you all, to people who work in the healthcare system, and saying, here are what abortion seekers think are the good and bad things about abortion access and about quality. But now, what do you think is important? And also, what do you think is changeable? So it's a 15-minute survey where you get to have your say and to say, these are the things I think are most important on pathways to care. Here's where we need to focus stigma reduction efforts, and here's where we need to focus quality improvement. It's also not just the negative, it's also here are the positive things that here are the ones we need to train towards. Here are the positive behaviors that we would like to see more of in our health system. And then by telling me which are more feasible, it also helps us as a research team decide where can we focus our interventions, where can we test some stigma reduction efforts. And if you'd like to be involved in co-design, there's also an opportunity to check a box, and then we can contact you once we're in like a co-design phase for intervention development. There is a draw for a gift card just to hopefully thank you for your time. And we've had great results in Victoria. We've had more than 100 people in Victoria answer, which is great. And then we've had 5 or 6 people in the other states and territories, which is why I was hoping you could just encourage a friend somewhere else who works in healthcare, even if they're not an abortion provider, anyone who engages with anyone seeking care. So it could be someone in pathology and sonography, just a GP, basically anyone who might interact with pregnant people. So that's the study, and I'm going to close it in a month. So there's all of March still to get someone to fill it out or to fill it out yourself and to have your say. And I'd love to hear if anyone has questions about the study as well.
I have put the link in the chat for people who maybe don't have the agenda on them.
Thanks so much, Kath.
There's a good chance to go and get a cup of tea and sit down and fill that out.
Yeah.
Are you happy, Shelley, for us to share it with any of our networks?
Yes, just not on social media, because we know that with abortion research in particular, there's a lot of fake responses. So if you're on a WhatsApp group and you have people you trust, colleagues, feel free to share it on WhatsApp or in a closed Facebook group, but just not in a public space, just because it's too hard to know who's faking it and who's real. But please do pass along. Much appreciated.
particularly interstate colleagues.
Yes.
I'll keep that in mind. And no questions for Shelley? And we really look forward to hearing back from you at a later time, perhaps at another meeting later in the year with some of your preliminary findings, Shelley.
Yeah, that's great. We'll be happy to share. And it feels like a lot of the things rising to the top are just kind of the barriers to care that will surprise no one, but hopefully can give us a way to advocate for what we all think is important.
Yeah, absolutely. Okay, thanks so much. Thanks for your time. Feel free to move on if you need to. All right, so Ellie, I'm going to hand over to you to talk about some very important research that I know you and Kate at the Northern have been involved in for quite some time.
Great, thank you. I'll just share my screen. And I have 20 minutes, is that right?
Yes.
Yep. Can everyone see that?
Yes.
Great. So I would also just like to begin by acknowledging the traditional custodians of the land on which I stand today, the Wurundjeri people of the Kulin Nation. And I would like to pay my respects to elders past, present and emerging and extend that respect to Aboriginal and Torres Strait Islander peoples here today. And I recognise that sovereignty was never ceded and that this was and always will be Aboriginal land. So as Kath mentioned, I'm Ellie or Eleanor Johnson if I'm in trouble or trying to be professional. I'm a research midwife at Northern Health and I'm a very early career clinician researcher. So I'm currently undertaking a Melbourne Academic Centre for Health MAC-TRACK research fellowship and I'm a probationary PhD student at the University of Melbourne in the Nossal Institute for Global Health. And today I want to present to you learnings from a research project led by myself and Kate Chowkey, who is the coordinator of the abortion clinic that runs through Northern Health at Broadmeadows Hospital. And the research is called Partnering with the Community to Co-Design Abortion Care in Melbourne's North. I'd quickly like to acknowledge my co-investigators. So obviously the incredible Kate Chowkey, who is a clinical midwife consultant. Also Professor Kathy Vaughan, Professor Lisa Hoy, Dr. Mridula Shankar, Professor Megan Boren, Professor Bodil Rasmussen and Dr. Jeannie Henderson. I want to acknowledge that we've received funding from the University of Melbourne as part of an innovation grant and a Victorian Nursing and Midwifery Trust grant to do portions of this research, and had other research fellowship support from the Melbourne Academic Centre for Health. And I, of course, also just want to acknowledge all the people that have been involved in this research, as otherwise we couldn't do this work. So big thank you to them. A quick note on terminology. I'm not going to talk about STOP or EMA, but what I will mention is I'm using the term consumer or consumer representative largely to mean people who have lived experience of accessing abortion care in the local region. Community stakeholder to mean individual groups or organisations that have an interest or stake in local sexual and reproductive health care, and we'll be using gender inclusive language. So just to start off with, this research came about because during COVID, Kate and I observed that the difficulties people were having in terms of accessing sexual and reproductive health services were potentially being amplified by the pandemic. And we are aware that there's a huge anticipated population growth in the northern catchment region, so anticipated 50% growth in the region by 2031. And we also have a really diverse community in the catchment. So we knew we needed to consider how to develop the service to cater to the anticipated growth and ensure equity and accessibility. We had ideas about how to enhance accessibility at our service, but we knew we needed to partner with the community to properly understand how to optimize care and access, as ultimately we only see the needs of the people that make it to the service and not necessarily the people who never make it to the front door, who might be the most vulnerable. And obviously are limited by what people actually share with us. So occasionally, you know, there might be things left unsaid. Just to start off with as well, I wanted, if I'm talking about, you know, changes that we're hoping to make to the service, I wanted to tell you how the service runs currently. Kate, the service coordinator, triages calls on Mondays, Tuesdays, Thursdays, and Fridays. Unfortunately, there is no cover on Wednesdays. Patients can be referred to the service by their GP, 1-800-MY-OPTIONS, another health service, and they can self-refer. Kate will do an intake assessment when she receives a call, and then will, you know, assess eligibility for attending the service, including their gestation, the medical background. She'll do a psychosocial screening and talk to the person about their abortion method preference, so stop or EMA, and then we'll book them in for the next available slot. Or potentially occasionally refer them to another service. So if they're over 14 weeks, they would go to another service. So we cater to 13 plus 6. Or if they're kind of very medically complex, they might also need to be seen at another service. And then she can also provide assistance to arrange outpatient ultrasound or pathology as needed. Then the clinics are run in person on Thursdays and Friday mornings. There are 5 to 6 stop appointments and 4 EMA slots available. If the person is having an EMA, they are first seen by one of the medical team. They take a history, discuss contraception preferences, sexual health and/or cervical screening. They prescribe the medication, and then the person picks that medicine up from the pharmacy on site, and they'll have a midwifery review before they leave, involving, you know, a review of psychosocial care, education on taking the medication, contraception and follow-up. If they are having a surgical termination of pregnancy, they're first seen by the medical team. Again, a history is taken. They discuss contraception preferences, sexual health, and cervical screening, and then surgical consent is undertaken together. Then they have a midwifery review, which involves psychosocial care, patient education on aftercare, and then they give pre-op MISO and pain relief and potentially antiemetics if required. Next, they'll talk to me. I'm a research midwife, as I mentioned, and I work on a project called the Reproductive Health Biobank, where we collect placental tissue from people who are having first trimester terminations of pregnancy, and we use that tissue to try and understand more about early placental development. So if someone is interested in that, they talk to me, and if they are part of the research, I then follow them through into theatre and collect that tissue. Next, they pick up their contraceptive script on pharmacy if they've opted in for the Implanon or the IUD, and head over to theatre. I just want to flag there are 2 ultrasound slots available through our Northern Pathology on site on Thursday and Friday mornings for people who haven't been able to access this in the community prior, and there's pathology on site. And depending on eligibility and availability, people can transfer between the EMA and the STOP pathway on the day. For people who are having a surgical termination pregnancy, then they head to theatre, which, like I mentioned, operates on Thursday and Fridays, but in the afternoons. They're checked in, seen by the anaesthetist, surgery is performed, and then they're recovered in the day surgery PACU and discharged to their support person. Finally, in terms of follow-up, for people in the EMA pathway, approximately a week later, they'll get a call from Kate or one of the other midwives for a wellbeing check and to discuss the process and see if the pregnancy tissue has passed. Then another week later, they'll get another call for a wellbeing check and to review their blood results to confirm that the EMA has been successful. If there are any concerns, this is then escalated by the midwife, and they discuss sexual health and cervical screening results if needed. If they're on the surgical termination of pregnancy pathway, they're generally recommended to see their GP 6 weeks post for a checkup, but they're not routinely followed up by the midwife unless there's concerns on the day by any of the clinicians, and then they get a follow-up review as required by the midwife on the phone. This follow-up occurs on Mondays, Tuesdays, Thursdays, and Fridays around clinic and triaging, and anywhere along the care continuum, the clinicians can refer the patient to be seen by a social worker for non-directive pregnancy counselling support, reviewing family violence concerns, safety concerns, and planning, etc. Now, sorry, back onto the actual research. So we have planned a mixed methods multi-phase research project involving collecting baseline data from the service, interviewing providers, doing a survey of consumers, and interviewing consumers, and then our co-design workshops, which bring together clinicians, consumers, and local stakeholders. The rationale behind having multiple stages in this research is that each stage helped to inform the design of the next phase, and it's allowed us to collect as broad a range of experience as possible and ideas for service improvement. Just in the interest of time, I'm just going to focus on the most recent results of our co-design workshops. They took place at the beginning of February, so this is very fresh. A note just on co-design. So co-design very broadly, for those who might be unfamiliar, brings together people to design something new. So a new product, service, or policy. And we used experience-based co-design in our workshops, which brings together patients, carers, and staff to improve services by collecting experiences, identifying opportunities, prioritizing actions, and then testing and adapting different solutions. The aim of our work was to develop a revised model of care at our service in partnership with consumers, providers, and stakeholders that is tailored to consumers' needs, that optimizes care, that promotes equitable access, and could cater to the growing demand. And in terms of who was involved in our workshops, we had mainly consumers, and the consumers lived in the Northern Health catchment or the surrounding region, so in Melbourne's north. They had experience of accessing medical abortion, surgical abortion, or both, and they had accessed this care in the community or in private or public services. They identified as women or gender diverse individuals, and their age ranged from 23 to 48. We had representation from the service in terms of the midwifery, social, and medical workforce in the abortion clinic. And we also had Aboriginal liaison officer representation from our Aboriginal support unit, Narum Willip Jin. And then we had representation from the incredible 1-800 My Options, the Abortion Project, the Multicultural Centre for Women's Health, and Women's Health in the North. The workshops involved 2 4-hour in-person workshops, and they were facilitated by myself, Kate Chowkey, Mridula Shankar, and Kathy Vaughan. The first workshop involved getting to know each other in a bit of setting the scene, and the second workshop involved reflecting and collaborating together to co-design the model of care. I am yet to run a secondary follow-up online workshop for the small amount of people who couldn't come in person to workshop 2, but that's in the pipeline. What we first did is a bit of introductions and kind of getting to know each other. Then we created a shared agreement in the room. So we talked about what atmosphere we wanted to create together in the workshops, what we needed for us to work together well, how we were going to deal with differences. And with co-design, it's really important to kind of lay these things out at the beginning to kind of create a sense of trust in the room. And obviously, co-design really thrives on diversity of thought, but that can also bring about the risk of disagreement. So it's really good to kind of get everyone in alignment about how we're going to act in that setting, first of all. And this is the shared agreement that we came up with together. And I won't go through each individual kind of question response, but what I really thought was great to see is that respect threaded through each of those elements, and it was a very respectful, warm, safe space. Next, we took some time to think about, as individuals, why we wanted to participate, what we wanted to get out of the workshops, and how were we going to know that we'd been successful. And we broke off into groups to actually discuss this, and then came back together as one big group. I don't have enough time here to summarize all the motivations, aims, and measurements put forward because they're actually very layered and multifaceted. But what I will say is that overwhelmingly, people at the workshops were motivated by a desire to improve services for others in the future, and they wanted to see real change and impact. So that was really nice to see. Next, we watched a short film that was created using the recordings of people that had been interviewed at an earlier stage of our research. So this video explored people's story of accessing abortion, barriers to care, and reflections and ideas for what we could do better. And those individuals kindly consented not just for us to use their voice recordings, but for us to use their video, which was really fantastic. And it provided an opportunity for people to reflect on their own journey, as well as other people's journey and the emotional points throughout, and look for kind of similarities and differences. Then we get to our second workshop. So next, we, as a group, reflected on our thoughts on the film, and more generally, more thoughts about the first workshop. And really naturally, it seemed a lot of ideas about how services need to be optimized based on people's individual experiences came to the front of conversation. It genuinely didn't even need a prompting question. It just kind of came. And what really jumped out was just how often the processes that people were going through to access this care can be so arduous, and how much resilience people needed to demonstrate throughout. So as clinicians, I guess often we just see the bit that we're involved in and not necessarily all the difficult points that can come before and after that. So what came to light is that people wanted a trauma-informed process as well as trauma-informed care. We talked about lots of different ideas on how to achieve that, and then we grouped these ideas into three main approaches. So creating a trauma-informed process at intake to our service, creating a midwife or nurse-led telehealth model for early medical abortion, and creating a trauma-informed process for people during and after their appointments or their procedure. We then, took the time to make sure it was laid out how the service looks currently, and each approach was allocated to a group, and the groups were given time to collaboratively work through how their approach would look and function, and if they could foresee any barriers or challenges, and if so, how these could be overcome. And then after lunch, I swear I did feed people. Each group took a turn at presenting their approach, and they kind of naturally just, let different people speak to different points, which was really beautiful to see. And there was time for kind of questions from the bigger group and additional suggestions. And so I've attempted to collate here the co-designed approach into one model, and the changes are marked on the right-hand side, but I think that's going to be quite difficult for you to see. So I want to zoom in on the individual elements now. The participants want to see that we at Northern Health develop our website. So we add to the website additional information about abortion care, contraception, and educational links, a video of what to expect on the day of the appointment or procedure. And they want us to have the option to provide an intake assessment online in addition to the existing phone intake with a midwife options. They don't want it to be one or the other. They want it to be both, because they recognize that some people will prefer the phone option, but that the online option might provide a better experience for others. The participants would like to see a midwife nurse-led telehealth early medication service as an option to enhance accessibility, and this would have serious benefits in terms of supporting all providers to work to their full scope and enhance resiliency of the service. So in that model, once the medication had been prescribed, it would then be mailed to the patient, or the script would be sent to their preferred pharmacy. They would then be linked in with the existing follow-up already in place for people that have accessed EMA through the clinic, and people that preferred to come in person and or would like a stop would follow the existing care model, but they would like point of care ultrasound by the clinician looking after them to be made available. And it was really valuable to have, obviously, the providers and consumers available to talk through all the different barriers as to why this isn't already in place, and then think about the things that we needed to do to address those issues. And that would mean that rather than having to make an appointment in the community before attending, or rather than going across to Northern Pathology and waiting for a slot on the day, they could just have this as part of their consultation at the bedside. Next, the participants would like to see pharmacological and non-pharmacological pain relief options such as heat packs to be optimized prior to stop to avoid unnecessary discomfort after taking MISO. And finally, in terms of follow-up, they would like a follow-up phone call after a stop to be the standard, but for this to be for people to be given the option to opt out of this for those who aren't interested. So we were really impressed by the ideas brought together by the group, and we look forward to implementing these ideas and wonder if people from other services might considering implementing some of these ideas as well. I just want to highlight that we got just beautiful feedback from the workshops, overwhelmingly positive, and it was lovely to see that, you know, everyone was satisfied or very satisfied with the workshops. I got some lovely quotes here from the free text section in the workshop feedback. So one respondent said that the workshops felt really impactful, like an opportunity to influence change. Another said their highlight was being able to share ideas, even as someone who has trouble speaking up, and that people from all levels of backgrounds could find common ground and find agreement in best care models. And then my personal favorite is that their favorite thing about the workshops was boss-ass women coming together to help with reproductive health issues. In terms of some kind of key takeaways, sorry, I'm aware of time, so please just tell me to.
Yeah, you're right. I've allocated to 1:45 actually, Ellie, so you're right.
Okay, great. Key takeaways from the work. First, just reflecting on the co-design process for people who might be interested in this methodology. Bringing together people with lived experience and clinicians requires quite a careful consideration of power dynamics. To make sure everyone in the room has equal voice in these settings, it's important to acknowledge that the power dynamics are there and spend some time establishing how you're going to address disagreements and hold space for the people with lived experience. So you can do that by asking them to speak first in group activities if they feel comfortable. Next, safety. So by that, I'm mainly referring to emotional safety. But obviously you need to keep everyone physically safe as well. You don't really know what sort of things that these discussions can bring up for people. And so creating that safe environment is crucial. Make sure people know that they can take breaks when they need and that they can come to you as a facilitator and ask for help if there's anything else that they need to feel safe. And also it's important to highlight how they can access support afterwards if the workshops bring up feelings of distress. And then finally, time. It takes a bit of time to build trust in the group, so it's important important to kind of set aside time for that at the beginning. And I also really want to advocate that consumer representatives that are involved in research need to be compensated fairly for their time. The recommendation is a minimum of $37.50 an hour. And if you can offer this, you're going to get more people interested in attending. And it's just a really simple way of demonstrating respect for people and their time and insights. The next reflection was about person-centered care. And of course, I don't need to say this in this group, but like it in any other area of care, obviously with abortion care, we need to adjust what we provide to the individual's wants and needs. A reflection that came up on the first point of contact was that some of the people involved in our work reflected that the first person they spoke to when they were trying to access a service, if they came across as kind of short or cold with them, then the person felt quite conflicted about proceeding with their care. If the person spoke about price before anything else, in the event that someone was trying to access a private service, that also kind of brought up some concerns. And if the person asked a lot of invasive questions without properly introducing their self or their roles. So I guess what I would say is in your service, it would be really important to try and make sure the person that is the first point of contact, so that's taking or making intake calls, is coming from a trauma-informed space and recognizes that, for a lot of people, it's already been quite a long journey to even get to the point of making that phone call. And just obviously kind of pretty standard, make sure they introduce themselves, make sure they introduce their role and why they're asking certain questions, and look after the people that are making those phone calls, because you don't want them to be getting burnt out. Then culturally and linguistically diverse individuals. Obviously, all the barriers that have been discussed are just further amplified for culturally and linguistically diverse people, because it's more difficult to navigate these referral pathways, and these individuals might be less likely to want to engage with services if they've experienced racism in the past when trying to access healthcare. So it's incredibly important to recognise this and ensure that these individuals are offered culturally sensitive and holistic care. And at Northern, we're really particularly lucky. We have a fantastic translation and Aboriginal support unit. Finally, people living with chronic conditions and or disabilities. So a participant that was involved in the research, who's a wheelchair user, reflected on a moment when she was accessing abortion care and having an ultrasound, and her wheelchair was moved out of the room because it was a cramped ultrasound room. There just wasn't a lot of space. And that was quite traumatic to her, because it was like her independence was being taken away. So I just kind of want to flag that as something to be kind of aware of. She also highlighted that consistently places can say they're accessible, but accessibility means different things for different people. And sometimes the accessible entrance is some really strange entrance at the back. So she highlighted that having a picture of the front of the service or really clear instructions on how to get to the waiting area can just remove one thing that she has to do every day. And then another participant highlighted that people who are neurodiverse might have difficulties communicating their needs and making decisions quickly about their, care pathway. So they might need a bit more time. Another small suggestion that they brought up was having small tactile things like stress balls or poppets or fidget spinners available for people to use in their service area. And finally, just a reflection on visibility. If possible, each service having as much information available online about what they offer is ideal, because ultimately having your local GP or health service be very transparent about providing abortion care often does more than offer just convenience to the individual, because they don't have to travel far, but it seems to assert that there's nothing exceptional about abortion and that it's just standard healthcare, something that you don't have to go to great lengths to access, which I think does a great deal to combat stigma. And that's me. Thank you. Sorry for sorry for going over on time. Thank you for listening. We've really only scratched the surface in terms of the research findings of our work, and I would welcome anyone to contact me if they're interested in the co-design work and would like to talk more about it.
Thanks so much, Ellie. Really interesting. I know it's too early to say, but just, you know, looking at the different pathways into the service, you know, having an online assessment tool that people can choose, you know, rather than waiting for a callback.
Yeah, and what was so beautiful about it is they told us exactly how they want it to look, what questions they want us to include on that intake form. And so when we come around to building that, we don't even need to do the work, really. The work has been done for us, which we're really grateful for.
Does anyone have any questions for Ellie or Paul?
Yeah, very interesting. I'm just curious, right at the beginning, you talked about, you know, intake and the various options of referring in. Just intrigued to know how much buy-in you've got from your local GPs with this, or are you still getting problems with GPs reviewing patients ad nauseum and then finally deciding to send them at 8 weeks, 4 days after all the tests and ultrasounds they can think of have been done, for example?
I would say Kate, the clinic coordinator, might have a better handle on that than me. But what she has flagged in the past is that actually the majority of the referrals to our service are self-referrals. But she does have quite, I think, you know, over 50%. I can't remember the exact number. And then I think she has done a lot of work on trying to create good networks in the community. I think there are some GPs that do consistently refer. But I'm sorry, I don't think I could comment further, but I could put that question to Kate and I could get back to you if you want to send me an email.
Just to say, thanks, Ellie, just to say, Paul, that we've just recently been reviewing the women's website, and we've sort of covered all bases there because we have requested that a GP will organise, you know, for a scan and some bloods. But on the other hand, we've said don't let that delay the referral altogether, you know. And I know one of the pathways within the abortion and contraception service is the scan and plan option. So yes, we know that it's a very common reason for people being delayed. There's Cara.
Hey, I know the Lyle McEwen Hospital in Adelaide has a midwifery-led EPAS service, which means also that the midwives are trained in ultrasound and can do the ultrasounds bedside. Is there any talk about advocating for the midwives in your service to be looking at that? Because obviously that takes away from paying for private ultrasounds in community and those delays.
Yeah, that came up in the workshop. So currently the midwives are working to get their endorsement that work in the service. And then obviously probably the next thing that we have to overcome is like actually getting the accessibility to an ultrasound during those kind of morning clinics. And then, you know, Kate really wants everyone in the service working to their full scope. So absolutely would be interested in doing kind of training for the midwives on that. Could you just tell me again the name of the service? So it was in Adelaide.
I've got an article actually, Ellie.
Yeah, that's the one I got referred to. So I tried to get it's Lyle McEwen Hospital at the in Adelaide, but yeah, and I've tried to get a nurse to contact them just to see if they'll share their protocols and what their you know, expectations are for midwives and their parameters.
Yeah. Thanks, Kat.
Actually, I can send this through too. There's an article in here about a endorsed midwife in WA who's doing early scans in early pregnancy care. So yeah, I can scan that and send that through too.
Yes, thank you.
Back to Paul.
I was just following from that. I mean, it ain't rocket science, is it? Early pregnancy scanning, and you know, things like the Lumify that Philips has got, the handheld one attached to an iPad or a Samsung Galaxy, are relatively cheap compared to the fancy ultrasound machines. I think they're at 9,000 from recollection when I bought mine, but that was a while back. You know, I accept the hospitals are cash strapped, everywhere is. But something like that wouldn't cost a lot and would certainly save an awful lot of time and the delays that everyone talks about to just get these things done.
Unfortunately, Paul, within hospital administration too, there's quite rigid credentialing.
Yeah.
And, you know, a certain standard of machine has to be used, and then
Okay.
individual has to be credentialed to the machine. So there are other kind of administrative barriers to developing nurse-led and midwife-led scanning.
Same.
Yeah, there's probably more examples of precedents in community settings, community health settings in primary
Yeah.
care.
Yeah.
Nurses and midwives, including advanced scope, are working to their full capacity. All right, there's some comments for you too, Ellie. Great workshop. Thanks, Anita. And Sarah's asking, would you be able to share these insights, you know, particularly the model, perhaps? I don't know if you want to share your whole slides, but
Yeah, you know, obviously I'll be working towards publishing these findings as part of my PhD work. But Sarah, if you want to connect with me, send me an email. You know, I can, you know, highlight when publications come out, and I'll be trying my best to look at other avenues for presenting the data that we've kind of gotten together at this point.
Yep. Keep us in the loop too, Ellie, and I'm happy to send it around to our networks.
Yeah,
Thanks. Just reflecting back on the whole experience, was there anything that was particularly stood out for you, or that was, you know, a new insight from having a co-design as opposed to, you know, following a guidebook or something? Was there something that you would say or, you know?
What came through in the workshops actually was that some people had been waiting for someone to listen to their experience for years and years and years, and they'd had potentially a little bit of a traumatic experience, and they just didn't necessarily have an avenue to feed that back to anyone, or they weren't sure how to feed that back, or it had been, you know, they had felt like they kind of couldn't revisit that because it had been a hard experience for them. So it felt quite, you know, emotional in the workshops to kind of create that space for people. I would say in terms of something unexpected, I think we had a lot of ideas of what might come up in the workshop as ideas for service improvements, but the online intake, it does seem really basic, but it hadn't been something that was at the forefront of our minds. So that just, and people really all really jumped on that idea. So that was kind of just an interesting thing to see that be something that people were quite invested in.
Because it could happen to their own personal timetable.
Yes, exactly. And then, you know, Kate managing these calls in between, you know, seeing other people, it just means that they know that they've, you know, given all the information that they need across to the health service. I think it would just give them a sense of security that they're not waiting for a phone call back whilst they're at work, or, you know, if they've got a partner that they don't want to know they're making this phone call, they're not worried about that timing, which I think is so powerful as well. Very simple.
It's true, Carolyn.
Thank you. I just wanted to throw out on the online form, there's a couple of things. So people really like being able to book online for an abortion for the services that are able to do that. Because often when we speak to people at 1-800-MY-OPTIONS, they might have already spoken to 4 or 5 different clinics, and they're really over calling places to get this sorted. And the online form is something that's done by Peninsula Health. They've got an online self-referral form, and people can put in a number of fields, and some of them are compulsory and some aren't. So I think if anyone is is interested in how that could work for their health service, there is a big one that's already doing it. And so potentially we can learn about how that's actually working in practice and how it helps people. Because I think another of the bits about abortion seeking is that you're often telling your story over and over again when you call a different service. So if you can avoid telling that story and just fill in a form and wait for the call to come through, that's again taking out one of those big, often insurmountable tasks from the journey.
And they're trauma inducing, aren't they?
Oh yeah.
Going and going and going. Yeah.
Yeah.
Oh, interesting. I didn't realise that Peninsula Health were doing it because, yeah, that's what one of my questions was, is there a precedent? So, yeah. All right. Well, thank you so much, Ellie. Really interesting presentation. Was that a question, Anita? Yeah.
Well, comment really. Thanks, Kath. Hi, Patty, Carolyn. Peninsula Health, I'm at Peninsula Health. So that form goes through to the sexual health nurses. So you've got to have the staff available to do those callbacks. And I agree, the submission of it's almost an expression of interest rather than actually booking a time slot. That's the difference, because the nurse then does all the work of, have you had a scan? What do you need? And the client can put times available where they are safe to have those conversations. That's
probably one of the, a big plus of it, Anita, because our experience is ringing people and they can't pick up the phone. Yeah.
Absolutely. So it definitely build in some efficiencies, couldn't it? And Carolyn's put the link in there. Thanks, Carolyn, in the chat. All right. Well, thanks so much, Ellie. Really interesting. And we will be keen to hear when you're ready to publish.
Thanks for having me.
Pleasure.
Pleasure. All right. A few people have dropped off, but anyone
Round up time.
Yeah, round up time. Anyone got anything that they want to let us know happening in their neck of the woods?
We usually use these last few minutes to share anything good, or if anyone's got a recent scholarship or find a crock of gold anywhere.
I can do a plug for sex rurality.
Yeah, put in a plug for sex rurality.
We've got a dynamic speaker on the second day.
Can you tell us how to say it? I can never say it.
Sex rurality. You have to say it with an American accent. I don't think Shelley's here anymore. But yes, it's going to be up at Shepparton in June. And Sophie, you can correct me if I'm wrong, but it's the 11th and 12th. And on the morning of the 12th, I think Dr. Patty Moore will be reflecting on, I'm not sure what you're reflecting on, but I think the journey and the history of abortion services, particularly recently.
And we were just, when we remembered that it was in Shepparton, one of my already reflections is that it was in 2012 that Chris Bailey and I went to one of the first sexuality conferences.
That's right.
Floated the idea of decentralizing early medical abortion.
Yeah.
It was really appropriate to have a bit of a look back and a look forward, and we're really looking forward to sharing that time with you all, because you've done so much, just so much in that time.
So yeah, links to register to the conference are through the Search website, so you can follow it from there.
All right. Thank you. Does anyone want to give a quick snapshot of what their service is looking like? Yeah,
yes,
great.
Anita, we'd love to hear from you.
Yeah.
We so I'm at each now in each and Peninsula Health. At Peninsula Health, I'm working in the pre-op stop clinic as a part of that workup and bookings. But at each, so we in the sexual reproductive arm at Ringwood East have a ultrasound we're public, no one is charged, and we are seeing Medicare, non-Medicare card holders as well, and can scan on site. They do have to pay for their blood tests, you know, on the day, and Medicare, their medication, and then 3 weeks later their HCG. We also have, I don't know if other services have this, the reciprocal Medicare number for UK clients. So they get the medication for normal Medicare price, the $30 or whatever, but the blood test they still have to pay for. And then we scan them on site. So there's myself and Dr. Jane Russell who scans. We have an amazing nurse practitioner who has just upskilled to do IUDs. 2 of the other doctors are doing LARCs as well. So in time, I'm hoping some of our nurses will look at ultrasound training. We're early in our journey.
Oh, but it's a great model. It's a really nice mixed model.
Yeah.
Yeah. And Kath and I are off to Mildura tomorrow. The last time we were in Mildura, we said we weren't coming back till the temperature dropped, but it hasn't dropped. But we're coming anyway to do some IUD training, and looking forward to doing that. And it's just another plug to say, you know, if any of you want to think about collecting a cohort of your own patients, we'll come and train on site with you. So to get in touch with us. Lou, do you want to tell us about the bus?
38 here today, Patty.
38, I'm not coming. No. Lou, do you want to tell us about the bus?
Oh, okay. Hi, everybody. Louise Holland here. Currently working as a nurse practitioner in the mobile women's health clinic van, alongside the breast screen van, Nina, who's been travelling to country towns. So I've been to Edenhope for 2 weeks. I've been to Dalesford for 2 weeks, and I'm currently, the next 2 weeks, we're working with the ACCOs. So we're in Bendigo at Bendigo and District Aboriginal Co-op, and then we're in Echuca at Nernda. And then we head out west to St Arnaud, Birchip and Warwick Nabil. So it's been pretty amazing. It's been an absolute privilege. And I suppose from a women's health services delivery perspective, the van sometimes goes to places that are fairly well sourced and serviced by great GP services. So it is about finding the cohort who may not go to those GPs or have difficulties going to those GPs. Or what I have actually experienced across the 3 sites now, I've been at Badak this week, is around people have actually been and have a GP or have a service, but they've actually got a question or a maybe just wanting a second opinion, or maybe wanting a little bit more information. Certainly, I've had some complex cases where people have actually been dismissed. Their women's health concerns have been dismissed by some services, and so they've been sitting there not sure what to do, because the natural, I suppose, progression for their GPs is to refer them to the services that they know locally, as opposed to have a broader view of where some specialist services are. So one of my objectives is to kind of do a join the dots process, so we can actually say to somebody that, you know, you may travel, 90 minutes this way and you get a service that, you've already been to and you haven't been very happy with it. So if you travel 90 minutes the other way, you might get to a service where it might be more acceptable. So, quite a few learnings. Some amazing people, just really generous coming, and some really great networking with the health services. So the van itself, if you can think about a repurposed tea room and a caravan kind of table and bench seat, that's where I'm working out of. So each community that we go to, we try and align ourselves with a community health centre, so we can rent or utilise a clinical room, just so that we can actually do some clinical work. So, take out implantons, put in implantons, etc. Clinician collected CSTs, examinations, things like that some people have been waiting and waiting because they haven't had anything nobody's had a look down there for 5 years, and they've been worried about something for a long time. Yeah, so it's wonderful, and working with the Aboriginal services is really great. So just walking around and meeting and greeting, and then someone will come in and have a yarn, and then off we go and sort some things out. So yeah, really enjoying it so far.
Great, fantastic. Well, we might have come to our
Conclusion.
natural
Yes, it is 7
conclusion.
o'clock. Yeah.
Yeah. Do we have another date? Tuesday, the 3rd of June will be our next one. Then the 19th of August, we'll send this out, but 19th of August and then December 2nd. But so 3rd of June will be our next meeting. And just to encourage you all, if any of you've got anything you'd like us to present on, or information that you would like, we've recently been involved in a woman who does quite a lot of drug and alcohol work here at the hospital. She presented to the Nurses Forum, and that was very well received. So if you're interested in her information about the drug and alcohol services and approaches, that might be something, because there's a real crossover between what we do and those kind of vulnerable communities. But any topics from yourselves, also greatly accepted. And once again, look forward to seeing you at the upcoming conference, and keep up the good work, and just really enjoying this ever increasing number of colleagues. So thanks very much.
Thanks, everybody.